So in the drug addiction, alcohol addiction treatment field in the mid-90s, we saw a convergence, I think, of three forces. The first one was the psychodynamic approaches to addiction. Psychodynamic approaches going back even to Freud, for that matter, I think to simplify that, but basically based on kind of the inner world of the people who had problematic relationships with substances. I think this largely was based on the idea that these people suffer from profound self-hatred, profound self-criticism, and if you are a treatment provider, you know, you see this with your patients, and also extremely high levels of trauma. The other dimension from the psychodynamic world was the incredible importance of the therapeutic alliance, the therapeutic relationship. Highly confrontational traditions in substance abuse field are not those that engender a strong, positive therapeutic alliance. Tragically, I think the psychodynamic model, which had a deep understanding of addiction, were not very effective at treating it. They didn't have good methods, although they had a deep understanding. Starting really in the 80s, we began to see the rise of evidence-based practices, psychological practices coming out of NIDA and NIAAA, of relapse prevention, the extraordinary work of Alan Marlatt, whose spirit is, I think, in this room in some ways. Motivational interviewing, the idea of ambivalence as a fundamental experience of the fundamental part of the addiction experience, and contingency management, a still neglected but incredibly powerful psychological intervention for addiction treatment. And the third one was therapists who either were in the cognitive behavioral camp or in the psychodynamic camp or some combination of the two, being inspired by harm reduction philosophies, this idea of gradual change, of empowerment of patients, of moving away from morality. And this led to the creation of harm reduction psychotherapy roughly in the mid-90s. And in my opinion, there was no finer leader in this field and no finer creator than Dr. Andrew Tatarsky. So.
Oh, no. The other one? Yep. Okay. So, can I suggest everybody stand up and stretch, because I'm just mesmerized by all of these talks, but also I've been working today for about 10 hours. And so what a great thing. Let's give everybody applause. You know, we came together because we believe it's time that we need a broad coalition coming together of stakeholders from every sector of society to create, you know, to come together to change drug policy and bring progressive treatment reform to this country. And this meeting and meetings like this, we hope, will really serve to help galvanize that. I was given about 10 minutes, so I want to say a few words about myself and a few words about what I hope to do. And so I'm here representing psychotherapy, substance use treatment. I'm an addiction psychologist. I've been in the field for many years, and what I've come to is the idea that harm reduction psychotherapy, harm reduction substance use treatment is really essential to effective treatment for the broad spectrum of people with these issues we've been talking about. If we have the kind of progressive drug policy changes that we've been talking about and that we're advocating for, and I think we're beginning to see that happening, we need to have a corresponding change in the treatment system. Treatment rather than or I should say rather bad treatment rather than incarceration can be worse than incarceration. And we recently read a terrible case study about a young man who was mandated to treatment. This was in the New York Times a few weeks ago, who was in such terrible treatment that he ran away saying he would rather be in jail, and then he overdosed that night. So we see the coming together of our terrible drug policies, criminalization of drug use, driving people into terrible treatment, and setting people up to overdose. So I feel like I've been in the field for many years, and I've been walking through the field gathering together good ideas and trying to put them together into a model that helps me to understand my patients better and struggling to come up with an effective treatment model. And so I'm going to share with you two fundamental ideas that I think we need to be integrating. One is that we are in the midst of a scientific revolution, moving from an old reductionistic biological disease model to what I'm calling a psychobiosocial process model of problematic substance use. The model shift is a key because I think that the way that we understand problematic substance use suggests how we treat it. And I think that if we don't consider this model shift and people continue to live with this old problematic way of understanding addiction, it works against our efforts to do good treatment. And it seems to me that this model shift toward a psychobiosocial process understanding helps us to understand why we need to move from abstinence-only treatment to harm reduction-informed treatment. So I'm just going to say a few words about the paradigm shift in understanding and a very brief introduction to the elements that I think are essential to harm reduction therapy and substance use treatment. I hope to whet your appetite to learn more. These are the ideas that we have fully integrated and organized our Center for Optimal Living around. So we have a comprehensive therapeutic setting that is completely committed to integrative harm reduction psychotherapy, and we're doing professional training and training to organizations based on this model around the country and around the world. And we're finding that not only is there this shift happening in our understanding and the way we're working, but actually the good news is that there's a kind of, seems to be an opening in the world out there that is, you know, to embracing these ideas more widely. And just a really exciting experience I had recently training in Manila and Jakarta with a room full of military people and government people and clinicians. The military were sitting about a third in the room with military uniforms, and they found these ideas to be so inspiring and exciting. You know, what we're seeing here in our setting about the need for a model shift is happening all over the world. What's been happening, business as usual, has not been working. So I think we're in a global crisis. We're not helping the majority of people with substance use issues, and the traditional abstinence-only approach is tremendously limited in its appeal and effectiveness. People don't go to traditional treatment. That's why most people in traditional treatment are mandated. So I think that we as communities and we as treatment professionals need to be grappling with this question. How can we make treatment more appealing? A colleague of mine once said to me, if the treatment that we offer isn't more appealing than the problem behavior that people are struggling with, why should they come to treatment? What a brilliant idea. So it's really incumbent upon us to create treatments that people actually want. And I think that the harm reduction shift really frames treatments that people will want. This is what I offer as a proposition, that harm reduction therapy can dramatically improve our ability to help the overwhelming majority that we have not been helping. Any statistics suggest that we're not helping the overwhelming majority of people that are struggling. So these are some ideas that I think are essential to this scientific revolution or this paradigm shift. We're moving from simple ideas, Jellinek's disease model, reductionistic biological disease, keep it simple, stupid, toward the need for more complexity, for a more complex and more nuanced way of understanding. From biological disease, which is often a cloak for moral and criminal models, toward a psychobiosocial model. One that I think, and I'll talk briefly about, is really an attempt to integrate the idea that there are multiple vulnerability factors interacting with consequences of chronic drug use that give rise to the addictive process. And clinical data, research data really supports this model. We're also moving, I think, from a categorical way of understanding, that is, you have the disease or you don't, toward a spectrum model, so that we're not talking about discrete categories of problems. We're talking about a wide variability in problematic substance use. This, by the way, is embraced now by DSM-5. And not only does substance use vary on a spectrum of severity, but it varies on a spectrum of multiple dimensions. So given this unique interaction of psychology, biology, and social context that's unique for each person, we see that this spectrum of problematic substance users are a spectrum of unique individuals that need unique solutions rather than one-size-fits-all treatments. So we're talking about really a new view of substance users, problematic use, and appropriate treatment. So abstinence only to harm reduction therapy. The society is dominated by this one-size-fits-all model. I think of it as reductive, as anti-meaning, and it really is problematic in so many ways. It gets expressed in substance use treatment that frequently won't treat people who don't embrace abstinence. That's abstinence only. So you don't get treatment for the problem that you're struggling with until you're ready to accept the conditions of treatment. And frequently, people die before they get to that point. And on the other hand, mental health clinicians who have bought into this model come to believe that you can't treat active drug users with psychological methods. So where does that leave the active drug user who's not ready, willing, or able to stop? With nothing. And then they're blamed for it. So, you know, what a setup for feeling worse, using more, and dying. So what is this model? We see on the top vulnerabilities. This is the way I understand addiction, that things don't cause addiction. You know, simple factors don't cause addiction. But we know that many of these factors are highly correlated with addiction. Genetics, trauma, deficits in affect and self-regulation, psychiatric disorders, life stress, despair, poverty, being the member of a stigmatized group, and so on and so forth. And these vulnerabilities give rise to this experience of a kind of unique fit with the substance. But that fit is not just around the biology of the substance, but the social meaning, the personal meanings. So there are multiple aspects of the substance that interact in unique ways with human vulnerability that give rise to that rewarding effect. I like the feeling. I want to do it again. It works in some way. That's a key, somebody mentioned earlier, the positive function. Now, as people use over time, all sorts of things kick in, psychobiosocial consequences. Of course, there are receptor changes, there are neurochemical changes, but also in a society that stigmatizes and criminalizes drug use, now people become increasingly shamed and guilted and anxious and stigmatized, and as a result, many isolate. You see, the disease model said addicts, a social construction, isolate. But in the social context of drug use, people need to isolate to protect themselves. But once people begin to isolate, they cut themselves off from help, from support, from sources of positive social interaction. And all of that contributes to an exacerbation of original vulnerabilities, increased shame, guilt, anxiety, despair, and increased drug use. So we've got this complex process that's set in motion of multiple factors interacting. So Bill Miller wrote in his chapter 2, What is Addiction, in his book 2011, which the title I can't remember, you know, that there are multiple dimensions on which substance use varies. I won't go through them, but I would add co-occurring problems, positive benefits, multiple personal and social meanings, which is a whole, important topic which we can't really go into. But also awareness dissociation. Some people are very aware of why they use, and others have no idea. The meanings are dissociated. What are the treatment implications? We must address substance use and all of the related issues concurrently. Vulnerabilities and consequences often need to be identified and in some cases addressed before people are in any way ready to begin dealing with their substance use. That's a key. And if we address any relevant issue in the system, homelessness, trauma, the biological impact on the individual, it's going to shift a person's relationship to the substance and their motivation. That's why we don't need to focus only on the substance or even on the substance to begin a process of positive change, to begin supporting people and moving in a positive direction. Therefore, we need to have treatment settings or therapeutic settings that invite people into the room while they are actively using. That is, wherever they are ready to begin the process of positive change. And that's the essence of harm reduction. So what is harm reduction therapy? Well, it embraces the core principles of harm reduction. People frequently make the mistake, I think, of equating harm reduction with public health interventions. But in the Harm Reduction Coalition's definition and the International Harm Reduction Association's definition, it's a set of ideas and strategies. It's a philosophy and a set of strategies that derive from that philosophy. 2 minutes. Okay. So these are the basic core principles. We shift from abstinence only to any reduction in drug-related harm, which, by the way, includes the treatment of addiction, which inherently is harmful. We start wherever the patient... No, so harm reduction is not at odds with addiction treatment. Addiction treatment falls under the harm reduction umbrella. If we start wherever the person is, we can engage. It's an engagement strategy for partnering with people and offering them something that they find useful as a way to begin that process. And we embrace small incremental change rather than requiring that people make quantum change as a prerequisite. And finally, we've heard about the inherent value and power of collaboration, empowering people to become actively involved in their use. We bring a therapeutic orientation to harm reduction settings and a harm reduction orientation to treatment. I'm going to take my last minute to say that I think that given this psychobiosocial sort of multiple factor model, we need to be thinking continually when we're working with individuals about the multiple dimensions that interact and need intervention. The Therapeutic Alliance is a key foundation for offering cognitive, behavioral, active strategies to support people in making positive behavior change, while also creating a space for deep inquiry into the complex meanings, as well as focusing on the body and people's social and community context. And finally, and this is what we spent 3 days in November doing an intensive 3-day training on the model. These are 7 therapeutic tasks that I think are key to effective help. The Therapeutic Alliance, that is creating an alliance in which patient or the substance user and the clinician are in agreement about the goals, which requires that we start where the person is. Around that, a facilitating relationship develops, and that relationship needs to be really tailored to that individual. What does that individual need from us? We also need to be thinking about enhancing self-management skills, the capacity to manage urges, manage discomfort, manage uncomfortable feelings, which are at the heart of addictive behavior. Then what we do is we set the stage for a collaborative assessment so that we don't begin with a conclusion about the patient's, the nature of their problem. We set the stage in relationship and skills building to do a collaborative assessment, to tease apart those factors that are unique. And a key, which someone mentioned, was embracing ambivalence. To the extent that the substance is actually helping in some kind of way, or in multiple ways, people will be understandably ambivalent about giving it up. So we need to invite the ambivalence into the room so that we can sort out, in what ways it's helping, in what ways it's hurting. And that dilemma then can lead to a consideration of positive change goals or harm reduction goals. If I'm using because I'm anxious and I don't want to become incarcerated or want to cut back or stop, I need another solution for my anxiety. So here's where the sort of addressing the substance use in the context of complex related issues becomes key. And now we can set about coming up with individualized plans for moving toward positive change goals. So in a sense, we turn the traditional approach upside down. Instead of beginning with an authoritarian prescription for recovery, we begin with relationship and therapeutic alliance, engaging people on their terms so that we can collaborate on understanding, goal setting, and coming up with individual plans. So that's it in a nutshell. I think that this can be integrated into existing treatment settings, which shift from, which can incorporate a harm reduction orientation in and open the door to this large group of people that have been kept out. Thank you.
So maybe we get all the speakers to come up here. So if you'd like to ask a... So if you'd like to ask a question or make a brief comment, or microphone there is one over here.
So I want to ask a bit about the difficulty in implementing some of the changes proposed both in education and in treatment, where at least it seems to me that a lot of what you called like the bad treatment that currently exists and a lot of the really bad education that currently exists is really, really easy. It's really easy type of treatment to provide. The therapists, the support groups that provide it are done simply. The teachers that teach this crap in our schools don't have to think very much. The people who enforce zero tolerance don't have to be very talented. And, we're talking here to, really people who are tops in their field who are talking about trying to spread these new concepts to people who aren't going to be as competent. And I'm wondering how can we actually, because you're talking about really complex solutions to complex problems, how can we make the people providing these services capable of actually doing that?
I can speak to the education piece, and then we can pass it.
So this is a question of dissemination, I guess, of new ideas and empowerment training. Okay.
Well, the education piece, I think, one of the things I've done at DPA over the last year is I've actually worked with the Department of Education in providing trainings, safety-first trainings for their rank-and-file prevention counselors. So I think part of the answer, and then I'll defer to my colleagues, I think part of the answer is winning hearts and minds and going at it piece by piece, because these groups that I have actually spoken to are groups of 30 and 40, right? So you talk about there's 400 of them throughout the city, we're talking about 10, 15, it gets to be kind of a weighty kind of thing, but it's worth it to us to do that, and I think that's what it's going to take, is you have to work with people individually where they're at to help bring them along, I think. I mean, in the education, the upshot of that is I distributed 17,000 copies of Safety First throughout the New York City school system this last year.
Yeah. So I want to begin with saying that I understood everything that Dr. Tokarsky said, that Andrews, everything he said. 10 years ago, I wouldn't have had a clue. And so I've got 3 decades in law enforcement, so I want to just begin with saying that this is a huge problem in the law enforcement community because we should be the ones diverting people to what the doctor has suggested. An excellent program dealing with treatment, specialized treatment for the individual, not this blanket treatment program that we're so used to. So how does that happen? Earlier, it was mentioned about the Law Enforcement Assistant Diversion Program called LEAD. They currently have this program in Seattle. They have it in Santa Fe. We're trying to get it in Baltimore and some other places. So what it is that when police officers are trained, when they come in contact with someone who's a user or even selling at low levels, because many of the users are selling so that they don't have to rob people, so they don't have to steal from people, so they sell drugs so that they can pay for their use. So when we come in contact with these folks, we don't arrest them, we don't place handcuffs on them, we fill out some paperwork that could lead that way, but for the most part what we do is we divert them right to a clinician. And they go right into a treatment program, which should be what our wonderful doctor is talking about. And the money for that, again, we take from law enforcement, we take from criminal justice and our prisons and courts. We have plenty of money to do this, plenty of funding to do this program. And that's how we do it. And one other thing, we in law enforcement don't even have to wait for a program like this because there's a chief in the state of Massachusetts, Gloucester, Massachusetts, who has said, if you have an addiction problem, come to our station and we will put you in treatment right away. But we need good treatment programs to put people into. So every law enforcement community department can start right now, today. And what that's going to take is for us, now that we have this magnifying glass on our criminal justice problems, mass incarceration, which much of that is about our war on drugs, this is a great time to start this conversation in the right communities with our policymakers, our legislators, and start educating people who make these decisions to make this happen. And we got to force them to do it at the grassroots level.
If I could just add something really quickly. I've worked now in New York City, but I've also worked in Washington, D.C. and in Puerto Rico. And I think what happens, I really feel like a lot of it has to do with advocacy and what happens in setting policies, if not state, then federal or national. Because what happens, in my experience as a harm reductionist, is I was very limited in terms of what I could do in Puerto Rico or can do in Puerto Rico right now, because the treatment modality endorsed by the government is abstinence only. There is no harm reduction, or what is harm reduction is so severely limited. And so that decision in terms of what is treated, what is paid by Medicaid at the local level impacts then the kind of harm reduction available to police officers, to health educators, to whatnot. So I really feel that advocacy, so that like lifting the ban on for syringe exchange at a federal level, like those are all things that need to happen because they will then impact what happens locally.
And I'll just add another dimension, that I think that just as drug users are stigmatized, the drug treatment system is also a victim of that stigma. There are many well-meaning, caring, loving, dedicated people in the treatment system who are underpaid, underfunded, the programs are undersupported. They're working with old ideas, so it's ridiculous. And as the retired major was saying, there's more than enough money, but that means that part of drug policy reform needs to include, as I was suggesting earlier, treatment system reform with the dollars that will be saved, so that we actually can provide quality treatment for everyone that needs it and wants it at whatever cost they're able to afford. And that needs to be a central pillar of drug policy reform.
From the perspective of my work with young people, with teenagers and young adults and their families, parents will come in with a the knowledge that's ingrained from the traditional treatment approach, they say, how can I talk to my children? My child is on drugs. What do I do? He has to stop. It's the focus on the substance. We know how to. We know there's well-tested, long-term ways that we know about how to relate to our kids and to raise our kids and to talk to our children. And we don't have to reinvent ourselves. These are things that we know that work. They're taught in the schools, but when the subject of drugs comes up, we freak out. So it's in a lot of the work with the families, it's helping them understand that you already, it's focusing on the relationship that you have with your child and the sense that's ingrained in them from the abstinence-only community. They don't have to do anything different. They have to reconnect with their child, and a lot of the work is around. It's almost like having people. It's like a propaganda, getting the propaganda out of the sense of what they need to do. So it's part of why we put together, we form Families for Sensible Drug Policy, is to educate parents. A lot of the parents will say, I don't know about naloxone. I didn't know about, these harm reduction approaches. Well, but you do know about how to relate to your child, and you've been doing it for your entire, the entire development of your child. So it's changing the narrative of treatment into, being effective parents, being effective, what makes healthy families. The substance is just another stress that's a part of the family. So.
And I would also like to add that there were so many great points that were expressed tonight. Obviously, patient-centered treatment and forming relationships with the individual is really paramount. And what happens through all this recycling through institutions and treatments is that the clinicians don't have the opportunity to form a relationship because they're starting at abstinence only, and if there's an issue with relapse, children are given black garbage bags and, told they can leave. I'd like to just say thank you to the Families for Sensible Drug Policy administrators who are also moms who flew here to be here today. Hi, guys. Really appreciate it. But it really does make sense. And in terms of, I also serve on my local drug awareness committee, and I like to say that there are really good people, and I think Dr. Tatarsky, you made this point before. There are good people in bad systems, and when you come from the approach that just speaks to humanity and states, wouldn't you like to have an opportunity as a probation officer to really bond, with your client rather than having to sanction them? They stop, and in all cases, they say, well, yeah, I would. I've never thought about it that way. So I think the idea that we're here getting the conversation going is just really wonderful, and it's very heartwarming, and that's what I wanted to share.
Looks like another question is coming here.
Thanks for everybody being here. I just feel like there's nothing anyone said that I disagree with. But, we all are doing this, and we're all involved, and we're hearing this. And it's just amazing to me that I can be talking to FSDP or someone else, and then I go out and I go to my grocery store, I talk to a neighbor, and I hear this blasting, well, I'm sending my kid to AA because of this and that, and it's very difficult. There's a big gap there because it's not. I think my main question, though, was how do we know, how do you know if you had a child? I have a big family. There's got to be lots of substance use and abuse and everything in there. Lots, it's all over the place. And they're coming up, too. They're growing up, kids. How do you know whether, if you're going to take a child somewhere, how do you know what the treatment model is? Like, how do you know that you're not, I got a niece that just went to drug court. They sent her to a rehab, a 12-step rehab that she got out of that, and she's going to AA, which makes her think that she can't take methadone, any medicine-assisted therapy at all, or she's not clean. So I'm saying, how do you even find out where you would, if you wanted to get a child help? I mean, do you call them and go, what's your model of treatment? Or do you, I don't even know how that, because that's all I ever knew back in, from years ago, is they were basically all 28 days and 12 step. Thanks.
Thanks.
Well, what we do when we find out, unfortunately, that we have cancer or heart disease or other medical problems, we do research on who the doctor's going to be, what the treatment's going to be. When a doctor offers us an opinion, we go to a second opinion. We don't do that. We haven't done that. But what we're starting to do is to begin to, like what I said before about when parents come in, we educate them that there are other treatment providers. Our colleague in San Diego, Tom Horvath, has an organization called Self-Empowering Addiction Treatment Association that just came out with a new resource. There's a website, and it's the harm reduction and other self-empowering professional providers are now becoming part of that resource guide, and it's a huge step forward so we'll be able to answer those questions of who to go see and be able to get the treatment. And part of I now do as a therapist is educate parents like you would with any other condition. Here are the questions that you need to ask about treatment. Here's the situation with my kid. He has an anxiety problem. He's got ADHD. Can you help me? How can you help me? And then ask, and then if not, then look for programs or places that can. There are more, but it's very, very hard to start to find them. So.
It's all very true. I think Tom's group, also Smart Recovery, has a listing. It's not very extensive, but it's a start, and so you can call one place and say, do you know another place that works like you? Another thing, I wasn't always at DPA. I spent a couple of years at the Partnership for Drug-Free Kids. I ran their parents' helpline. Very different work, very different organizations. By the time they realized who they had on board, I was already at DPA. That was the good news. But one of the things that we would do there is that we were big promoters of the CRAFT approach, the community reinforcement and family training approach, which is a positive reinforcement approach to helping people get the help they want and encouraging people to get the help they want. And I would tell parents, get the CRAFT book and take it to your local therapist. If there's no one's practicing CRAFT in your town, maybe, and maybe they'll be open to that. And I think you bring up a good point. We get a second opinion for lots of other elements, but even for less serious things. I know I'll shop incessantly, obsessively, online to get $5 off of a deal, right? And I'll go to 16 websites before I make my purchase. But yet we'll go to the first therapist or we'll go to the first clinic, and we won't make any other critical decisions about working with them. Those are just a couple of thoughts I had as that question came up.
Hey everybody, I want to thank you all for being here, and I'm pretty proud to be part of FSDP. I think there's a lot of moving parts to this problem. One of the things that doesn't also get talked about is when parents are facing this issue, insurance denies them care. There doesn't seem to be a conversation about what do we do about that? How do we petition providers to allow for that? I had wonderful health care. I had a fight tooth and nail when my son was actually ready. He had to be told to use. He was told by the people at the place that was getting ready to take him, just use until we can get you in here. To a parent, especially after he'd just been released from prison, that's appalling. And I don't know that the group can necessarily speak to that, but I know that there's a lot of holes here that people are just falling through. And, you know, how do we get to work with the judges who are sentencing these kids and not understanding that there are all these cracks for them to fall into?
I can say a little bit about that. I mean, the situation is horrible. I hear this all the time. There are opportunities, and there's a sort of movement building, both for treatment of substance use as well as mental health, around enforcement of parity regulations, which say that, according to the law, that your insurance should treat substance use or mental health claims just the same as other kinds of physical health claims. There's a lot to be worked out about how that's going to work, and a lot of people are unsatisfied. Here in New York, the Attorney General, the State Attorney General, has taken some enforcement actions against some insurance companies where they've been able to substantiate claims that people are getting denied coverage for behavioral health in ways that are discriminatory. But right now, we don't have a clear kind of rules of the road, and so, you know, the next state over, they might not have the tools or the resources or the political will to make those enforcement actions. I honestly think that there's more that could be done at the federal level to provide those rules and guidelines and to support state-level enforcement. And there are people who are working on that. That rally I mentioned in DC on October 4th, Unite to Face Addiction, includes some people who are very involved in doing that work. And I believe there's a website called, I've seen a couple of websites that are trying to aggregate some of this stuff. I think there's one called Parity is Personal. I'd have to go back and look, but I can try to connect you to them. But I think that this is a story that we're hearing over and over and over again. And that it's going to take some legal action to make this treatment that people need much more available.
And I would also suggest it needs to be the right kind. I'm not just saying, you know, look,
Yeah.
you mandate somebody into treatment and we have a situation like we had with this young man
Right.
dying. It needs to be the right type of treatment.
I, for one, being very familiar with the court systems, I have absolutely no faith in drug courts programs. And I'll tell you why, especially for someone who's just there because of their problem of addiction. You know, if other crimes have been committed, then deal with those according to the law, but you still have to provide the right opportunities for treatment. We need to continue to work towards, again, a Portugal model, where someone is discovered to have, you know, their personal supply of drugs on them. Something happens where, you know, they end up being introduced to law enforcement because of drugs. They need to go before a panel of health care practitioners, not a judge. I think there's very, very few people, if they are properly embraced, who would refuse such an opportunity. You know, people realize when they're in trouble from drug abuse. And if you give them what they need, the wraparound services that they would need, and many suggestions that we've heard here today, they're going to take advantage of them. And forced treatment is far more problematic. You know, there might be out of maybe, you know, a couple hundred or 1,000 people who have been forced into treatment and say, wow, it really helped me. But I tell you something else. If they had an opportunity to be introduced to a system that what we're talking about here, I think they would say, well, yeah, I would have taken that first because now I'm not stigmatized with an arrest and a conviction record, which is preventing me from employment opportunities and other advancements in my life.
Right. Thank you.
What's the time frame you guys think it's going to happen, this whole thing? Because federal, there's always a gridlock. I mean, by the time it trickles down to the ones who need it.
So I guess the question is, how long is this going to take, or how long do you think it's going to take?
The actual, because you said you do better in federal, but you need it in local. And the system is just so, how should I say, complex that in each part of that system, there's a problem. It may be minor, but it
adds up to a big problem.
I think a shift is occurring. When I began doing this work in public health, it was 2011, and there may have been 6 or 8 states that had naloxone laws, and maybe a handful of Good Samaritan laws. Since then, there are half of the states in our country. I'm from Pennsylvania, and Pennsylvania, when we started working on the overdose prevention laws there, there was an incredible pushback. The idea that I could proudly say that we have a Good Samaritan law and a naloxone law in Pennsylvania is incredible, because 3 years ago there wasn't even a talk about it. So there is, at the policy level, at the legislative level, things starting to happen. And again, with the legalizing of marijuana in more states and medical marijuana. So it is starting to happen. And it took, if you look at the civil rights movement, I mean, in the 50s and 60s, or in the 60s, there's the movement began. We still have a long way to go, but there's like an arc of change over time, or the AIDS movement in the 80s. 30 years later, look where we are there. So I'm trying to look at it from that perspective, because I don't know if I'll be here 20 or 30 years from now, but in the short term, there is a definite movement in the right direction. So that's the way.
I just want to say this next decade is actually critical. There's a saying that the opportunity of a lifetime is only good for the lifetime of the opportunity. And we're there right now with this criminal justice movement. It's linked. They're dovetailed. They're joined at the hip. And we have to hold on to this momentum, not just hold on to it, but continue to build until we get to the tipping point. Just like with cannabis. I think we're just about there at the tipping point for cannabis. We need to do the same thing here. And the families that are coming out now, putting a face on this issue is critical. For years, there have been faces on the other side of this issue, which have led to a lot of these archaic policies of complete abstinence and prohibition that we had. And now we're putting faces on the other side of the coin. And I just want to say just one more thing that we haven't really talked much about tonight, and that is we're dealing with a public health crisis also from the policies of prohibition, which are causing most of the violent crime that we have within our communities. We're losing a lot of lives from people who are trying to capitalize, who are trying to control corners in our impoverished communities. Those who are out there selling drugs, recruiting child after child after child into these illicit drug networks. We have to find a way, even if it's partially, to move into regulated markets. Now, what I mean by that could be a supervised injection facility like we do in some of our countries in Europe, where we provide a regulated dose. And what's crucial to that, a regulated dose, is quality control standards. A lot of what you're talking about here tonight regarding overdoses and overdose deaths, it's because, yes, the mixing of substances, but who knows how potent that pack of powder is. And it's not getting any better. When I was working undercover in 1980, 1.5, 2% pure, maybe 5% pure. Today, on average, 50 to 60% pure for heroin. Philadelphia, 80% pure. Same with Baltimore. You don't know. You don't have a clue. You don't know if it's fentanyl laced with that. As we move into this place of harm reduction and properly dealing with those who are addicted, we can shrink these illicit markets. We can make it no longer profitable for the corner open-air drug markets, which is literally selling unknown poison to people. So that's something else that we have to focus on, because shrinking those markets will make it safer for those who are addicted, and it will also make it safer for those communities regarding the competition of these many young people in our poor black, brown communities that are selling these drugs.
Could I just add one thing about the opportunity for change? In terms of the treatment system, I think we actually do have an enormous opportunity for change, because the drug treatment system has traditionally been completely outside of the rest of the healthcare system, right? As, under the Affordable Care Act and other broader transformations in how we deliver and pay for healthcare, parts of the drug treatment system are getting pulled in to that. And that comes under the auspices of both regulation and different insurance payers in the midst of a broader kind of structural change towards moving towards paying for not episodes of care so much as outcomes and value. And the forms of treatment that are able to prove themselves to be most effective at engaging people, at retaining people, at getting good successful outcomes, at hitting quality measures, those are going to be the ones that prevail. And the less successful, less evidence-based ones, nobody's going to want to pay for them anymore. That's not going to happen automatically, though, because part of it is, I think that we've heard, some discussion about changing the paradigm, changing what success looks and sounds like and how we measure it. But this is kind of the biggest opening that we've had to radically overhaul the treatment system, because we suddenly have different financial incentives aligning in the right direction. So I do think that there's progress in that that's possible over the next 5 to 7 years, but some of it's going to be incremental.
But there's, the treatment industry is a $34 billion a year industry. There's a huge inertia there, and people like Hazelden and all the other crap treatments based on Hazelden, they're going to lobby like hell and say, well, we're the only thing that works. That's the same thing they've been saying forever. This is going to be a hell of a huge fight. That's a hell of an economic inertia to overcome, and it's really difficult to find any type of harm reduction-based treatment that insurance will pay for. It's hard enough to find it at all. And then when you find it, the insurance won't pay for it.
And it's a fight that we have to have, though.
Let me paint even the worst picture now. A glance at the SAMHSA website called NREP, the National Registry for Evidence-Based Prevention Practices, NREP. If you whittle the, and that's a listing, a database of model programs, which are evidence-based. What's the evidence? I don't know, but they're model programs, and if you want to have a prevention program, you have to use one of these model programs to get funding. So there's 133 drug prevention programs in this NREP database. Not one of them. Well, no, that's wrong. There is one that practices harm reduction. That's the BASICS model that's actually being used at the New School. Is the only education, prevention, intervention model that's evidence-based. BASICS is the only one that embraces harm reduction. There's 132 others that are out there, ringing in the dollars, but really doing nothing of any consequence.
Actually, to be a little more positive for a second, and I think she's next, by the way, just in terms of comments. Money follows consciousness, and things are happening. My battle was the battle between psychological treatments, even absence-oriented, versus 12-step. That was the battle I fought for, and now that's like everybody's doing relapse prevention, everybody's doing motivational interviewing. But that was a huge battle where people have some control, some power over their addiction versus they're powerless. That battle raged on for, now it's like, everybody accepts it. Andrew's got an extraordinary center here. There's Tom Horvath has one in California, the Center for Motivation Change. Things are happening quite rapidly here. And I think this is the most amazing time. I think it's not a time to be pessimistic at all. I think we're seeing extraordinary change. I think clinicians, I talk to people at Oasis, they're frustrated because they're told what they have to do, but in their hearts they want to be much more like the kind of humanistic care we see up here. So I think things are happening. I don't think we should be, money will follow consciousness. When the things change, the money will be there. I think it's really about thinking and people saying, I want a better kind of treatment. Catherine, I think you're next, if I can.
You kind of just
use the microphone, please.
Question. But I wanted to say that in terms of, I'm very fortunate to have educators on this panel, people who taught me about this, which is really cool. But how do you guys envision with, like, the next generation of caretakers, people who would be becoming doctors or, school advisors or therapists or treatment workers, police officers, really being people who would be the ones to embrace this and start to implement it next and want to, but can't afford all the trainings maybe? Like, I know people who are interested in getting involved in this, but they're so in debt from school that they can't afford to be in a profession that's not giving them money or do further trainings to learn how to implement this better. If we're talking about addiction as more complex than the past treatments have acknowledged, that means more complex education as well. So how do you guys envision providing that to the next generation of providers?
Take Andrew's course in integrative harm reduction psychotherapy.
No, and
That's right.
No, and I also want to echo what Scott said. I feel tremendously optimistic. You know, first of all, I want to say that I think everybody in this room has to step up and become a leader. I mean, that's how the world changes. That, you know, each one of you in your institution, in your community, in your city, in your state, step up and start, you know, a local harm reduction coalition office. Start having professional meetings or parent meetings or criminal justice professional meetings. We're finding as we get the message out, people are hungry for this and finding us on our website. People are tooling around looking for non-12-step or empowerment, you know, treatment or, you know, self-empowered, whatever. And it is a grassroots movement. You know, addiction treatment changes have always been driven by the grassroots. That's what AA was, that's what the TC movement was, and that's what harm reduction is right now.
If I could just add that I don't necessarily work with students who are studying in the health professions, but I do work with student leaders at the New School. We call them peer health advocates. And one of the things that we do is talk about harm reduction and about how they can utilize that for both self-care as well as they develop programs for their colleagues, for their peers. And I think the model of promotoras de salud and other models that exist in terms of public health 101 out in the community, doing everything from health literacy to labor organizing, where it is that peer model. That's what naloxone does as well as the opioid overdose. It's drug users advocating and taking care of themselves and of each other. And I think we really need to bring into the conversation about how drug users have to be at the lead of this. They have to be the ones that are doing the capacity building and the organizing and teaching us. And so I think that's an instrumental part of capacity building for the future in terms of the healthcare professionals.
And I wouldn't want people, and I'm not a therapist, I'm not a clinician, but I wouldn't want people to take away from today, we have these new models that are so much more complicated than the older models, but don't worry, they're better. Because that, at least as a layperson who's worked in harm reduction, that has not been my experience. My experience is that harm reduction can be very intuitive. It does not necessarily require a degree at different levels. And I don't think that the things that, for example, Andrew is proposing, I think he has a great framework, but I don't think this is like you need to go into debt getting a postdoctoral fellowship or whatever people in school do these days. But like, I don't think that it's about we've got to go from the old simple ways to these newfangled, more complicated ways. When we talk about nuance and when we talk about complexity, we're talking about humanity, but we're not necessarily talking about stuff that is, it shouldn't be rocket science.
Well, we've been training, we've been working with Housing Works, who has the first and only OASAS licensed program in East New York, Brooklyn, that is organized around integrative harm reduction psychotherapy. And we're training their staff that range from KSAC interns to social workers to nurses. And we're also training an organization in southern rural Ohio called Integrated Services, who are bringing these, integrating these practices with both, licensed professionals, but also outreach workers who go out into rural homes, knock on doors, and engage people in harm reduction psychotherapy. So, yes, we're developing models that we think can be adapted to, widely in different social contexts.
And I think as Major Franklin expressed also, that in the 20s, the ideology was there. So we need to also encourage court personnel, we need to encourage physicians, we need to encourage anyone and everyone who may have some touch, educators for sure, with an individual who is at risk or vulnerable for substance use or misuse, so that they have the sensitivity and the distinctions to possibly make different decisions. And perhaps this is something down the road that might even be mandated, just as other things are mandated in completion of curriculum. So.
And let me introduce.
Okay.
Getting back to the question about how do we, what's the next generation, to educate the next generation. So I had the pleasure of meeting Dr. Sandy Gibson from the College of New Jersey last month, who is doing some great work in terms of education. So you were about to ask a question, so
I wanted to answer the question from the student who was speaking. One of the things that we do at the college, we have an addictions counseling track for our masters in counseling. We teach all 3 of our addiction courses in Portugal every summer, where we actually go and we meet with the European Commission on Drug and Alcohol Addiction, which is an entity of the EU. We go to the Persuasion Commission meetings. We meet with the Persuasion Commission panels, with the government legislators that developed it, with the grassroots workers that kind of created the policy and made it come to a reality in a very conservative Catholic country, how they were able to bring this to be. We go to they're able to get people in treatment same day. They don't mandate treatment. I know you were talking earlier about you can't imagine people not wanting to accept that kind of treatment, but there are a lot that don't want to accept that kind of treatment. And they do recommendations and make them they call them presentations. So if the panel recommends that you receive substance abuse treatment and you don't want it, you don't have to have it, you still don't go to prison, but you have to do 50 presentations. And those presentations, you would think are lectures or something, but they're not. You just go to the job training program or to the substance abuse program or wherever they tell you you have to go, and you sign your name in a book 50 different times. So you know how to get there, you know the person who works there, you develop a relationship. So later, if you change your mind, you know where to go, you know who to talk to, you have that dynamic. So it's a very experiential opportunity. There's the policy course, the prevention course, and the treatment course are all offered over there. And they're blended, so you do about half the work online before you go so that we can spend the vast majority of the time in the field visiting site visits and seeing what this policy looks like. And we've actually reduced the cost, when you're thinking of cost, we've reduced the cost of the credits to take it internationally because you're not on campus, so we're not using campus resources. So we worked with the college to reduce the cost of the credits, and that actually covers the cost of airfare. So the students all kind of pile into an apartment and make it this experience. And so it's a neat way to do it, and there's opportunities like that, because there are students in our program who want to specialize in things we don't offer, and we let them transfer in 3 courses from anywhere else they want to go. Most programs do, so that it's not an additional cost on top of your degree. It's just something you transfer and play around. So there are opportunities out there. Every one of our students spends several days working on a needle exchange program. They're all trained in administering Narcan. They all have their own Narcan. So there's all kinds of really great opportunities out there that don't have to be additional add-ons for students who are in the field. But I wanted to talk about the National Registry of Evidence-Based Practice and Programs, because I would love to see more harm reduction on there as well. And I'm wondering, specifically with your treatment program and the model that you have developed, have you done any randomized trials? Because that's what it takes to get on that registry. We have to have randomized controlled trials. And I don't see a lot in the literature. I'm always looking for it, but I'm not seeing it in the literature. So until we get behind our practices with the science, we're not going to be able to get to that next step that we want to be in, and being able to take this and get that federal money, because we have more programs in that registry that we can use when we write our grants.
Well, until recently, NIDA told addiction treatment researchers that if you want to get funding, call it whatever you want, but don't call it harm reduction.
Well, you don't have to, yeah.
That's a quote.
Yeah.
No, that's a quote. So and I'm not sure what NIDA's policy is right now, but that effectively prevented funding going to, look at harm reduction psychotherapy. But there is currently underway an effort called the Harm Reduction Therapy Project, which is being spearheaded by Pat Denning and Jeannie Little, and has about 15 clinicians and researchers who are working in harm reduction therapy coming together to create a very large study that a number of different people at different sites around the country are contributing to developing the protocols and the materials, outcome measures, and will be buying in to collecting data and sites that will go into a central database, and we'll be able to actually begin answering
Marvelous.
the questions.
So that will start
That's
changing
underway
that
right
conversation,
now.
right?
Yeah, that's
going to be a
underway.
game changer.
Yep.
Fantastic.
Okay, because of time, I'm going to take this last question, and then we'll just keep like 5 minutes, and then we'll call it a night. So.
Great, thank you. So my question, I do see this, an increasing acceptance of harm reduction philosophy, as folks have stated, the expansion of Narcan laws, but at the same time I'm observing this other movement towards coerced care and the expansion of assisted outpatient treatment laws. In New York, it's known as Kendra's Law. Situations where not only are people being mandated to be in treatment, but a specific type of treatment is forced upon people, so even if they're required to be in treatment, they don't have a say in it. I'm seeing the erosion of HIPAA protections. There's the Murphy bill on the federal level, which probably won't go through this year, but it's in a better position to pass than it was last year, and it'll probably keep getting introduced. And that, impacts people who live with, the label of addiction, but also other psychiatric labels. And I'm genuinely very scared as I look forward. I don't know exactly where it's going, and I do see I see not only movement in that direction, but momentum. So I'm wondering if anyone could comment, or if folks could comment just on your general thoughts about that. Feel free to take it anywhere you're going. It's something I've been trying to puzzle through in my head.
Right,
Thank you.
So the essence of your question is there's also a movement to really federal or legally direct and control the treatment. Is that what you're saying?
So assisted outpatient treatment is essentially like in the way that somebody could be legally committed to a psych ward. It's legally forcing, and there's also a movement to increase that sort of commitment, but to forcibly medicate people in the community or provide other treatment under the argument that those folks are violent. But it's very broadly applied, and it's theoretically not through the criminal justice system, but is enforced by law.
I'm really ambivalent about this stuff. My organization's been doing a lot of work in Kentucky, and Kentucky is really kind of at the forefront, has been at the forefront of the prescription opioid crisis, and more recently, especially in northern Kentucky, the heroin crisis. And we went down to northern Kentucky, which is a pretty conservative part of Kentucky. It's kind of outside of Cincinnati, across the river. And we did a training, I don't know, a year and a half ago. It was organized around harm reduction. And I met a mother there, a parent activist, who's really a fantastic woman, who lost a son to overdose several years ago. And she lobbied to get passed a civil commitment law because she felt that if she had had the opportunity to go to court and get a court order so that her son would have to go into treatment, then he might not have died. And she did not want other parents to suffer the way that she did. She didn't want other kids to lose their lives, because the idea being that they weren't able to make that decision for themselves at that time. And that became a whole theme of our discussion that morning. And that had been a kind of obstacle for, what does harm reduction mean? Does it mean that people are fully capable of rational decisions and responsibility for everything? Is there some impairment? Where does the line go? And I've been thinking about that conversation a lot over the last year and a half, because there are other models of those laws. You mentioned Kendra's Law. There's, and that one, there has been some research behind, at least, that's being used to justify the bill that Congressman Tim Murphy from Pennsylvania has introduced to reform mental health overall. It's a big point of contention amongst a lot of the mental health groups. It also is very critical of the role of the Federal Substance Abuse Mental Health Services Administration. And its overall approach is ostensibly to redirect that federal agency's focus from broad mental wellness and prevention efforts towards narrowly focusing on severe mental illness. So there's a lot of kind of complexities in play right here. I think the pieces that you're talking about those HIPAA protections, right now, there is a push for family members to say, well, I want to know if my son, if my daughter was admitted to a treatment program, and I want to know when they're discharged because I'm their caretaker, I'm worried about them. And I understand that on a very human level. You know, some senators who I respect a great deal and have been very committed to this issue, to naloxone, to the whole spectrum, are saying, isn't this a good idea? And I think that this is something as a broader community that we need to kind of sit down and talk through amongst the harm reduction world as well as the mental health world that's been struggling with these issues for a while, because, you know, and come together with some of the parent and recovery groups that are active in this space, because I don't think we're all on the same page here, and I think that we need to come up with some shared messaging and understand each other's points of views a little better and what some of the possible pitfalls are for some of these approaches that have been proposed.
So with that, I'm going to bring things to an end for today. Amazing panel. Round of applause, please.
Can we have a round of applause for Scott Kellogg, our moderator, as well?
So thank you for coming. I'm sure people will be around to talk a little bit and